Welcome to Hospital at Home for COVID, What We've Learned and What We're Learning, a webinar sponsored by the Hospital at Home Users Group, presented in partnership with the American Academy of Home Care Medicine and the American Hospital Association. We would also like to recognize the generous support of the John A. Hartford Foundation for the Users Group and this webinar series. And this is just some of our social media and where you can access our resources. And look, this is also our webinar series that you can access on our website. It is now my pleasure to introduce our moderator for today's webinar, Dr. Linda DeSherry. Linda DeSherry is a member of the leadership team and a national expert on hospital and home implementation and practice, and she is the Vice President for Clinical Strategy and Implementation at Medically Home. Previously, she was at the Mount Sinai Health System for 18 years and was the Clinical Director of Mount Sinai's Hospitalization at Home program. Please take it away, Dr. DeSherry.
Thank you so much, Gabby. So I wanted to give a few updates before we get into the meat of what we're going to present today. And I think most of you already know about this, but if you don't, I wanted to mention that last week, twin bills were introduced in the House and the Senate to extend the current waiver that exists for the DRG payment for inpatient Medicare reimbursement. It was sponsored on the Senate side by Tom Carper and Tim Scott, and on the House side by Blumenauer and Westrup. So please take a look at this and make sure that everyone who's involved in your programs knows about that this is currently being moved through the Senate and House processes. So today's webinar, we're going to talk about COVID-19, what we've learned and what we're learning. And we're going to do this a little differently than we've done webinars before. Previously, we might have one speaker, then another speaker. But instead here, we came up with a number of questions, and we're going to kind of go back and forth between our two speakers to hear the same response to that question. What we're going to start with is a little bit of background about their hospital at home programs and specifically COVID-19 as just a background before we get into the questions. So I'd like to move on to introduce our two speakers today. I'm very happy that both of them were able to join us. We have Taki Michailidis, who's the medical director of the hospital at home at UMass Memorial Health. And we have Mike Maniaci, who is the enterprise physician lead for the advanced care at home, and he's the medical director of the Mayo Clinic Hospital in Florida. So thank you both. And we will go ahead and get started. So as I said, we're first going to start with just some general background to kind of lay of the land of the two hospital at home programs. And I'm going to pass it off to Mike.
All righty, we'll get started. So hospital at home, also known as advanced care at home at Mayo Clinic, started in 2020. We have a virtual hybrid program. That means we have a command center with a physician and bedside nurse remaining virtual. They give the care and implement it through supply chain and in-person resources in the patient's home. We began moving to the COVID environment late 2020. One thing I pointed out here is the way to keep people out of the hospital is advanced remote patient monitoring. We did have a robust RPM program of just phone calls and in-home monitors. We're able to monitor over 4,000 patients with our RPM program. It shows that you can monitor people and keep in touch with them. It also shows how easy it is to scale a monitoring system when it comes to actually delivering hospital level, inpatient level care. Much harder in the community to do that, even with advanced resources. Over the last year, we've taken care of about 161 home hospital patients with COVID. That's about 850 patients total. So about 20% of our patient diagnosis was COVID. We began in Northwest Wisconsin and Florida in late 2020. Once we understood COVID, understood what we could take care of in the home setting. Then when we expanded our program to Arizona last year, we advanced that COVID diagnosis and home hospital to our COVID patients. Some demographics just listed below. Most of our patients, 50-50 on male, female, about mostly white, non-Hispanic, mix of about 2/3 Medicare and 1/3 commercial payers. You see that our census with our hospital home patients kind of went with the surges. As the surges came, So did our hospital at home patients with COVID. We escalated about 9 patients back to the brick and mortar hospital, so about 5%. I told my staff that, you know what, I expect 10% escalations with all our hospital at home patients. It's okay. These people are inpatient level care. If we're not having high acuity at home, we're not taking the right patients to our program. So we set that expectation. It was a bit below, which is fine. We really found out how to take care of these people well. But that's our pace. That's our program in a nutshell.
Great. And now we're going to turn it to Taki.
Great. Well, Linda and Mike, it's a pleasure to be here. And Gabby and Kathy, thank you to the Hospital Home Users Group and to the John A. Harper Foundation. It's a privilege to be here. As Linda mentioned, my name is Taki. I'm an internist by training and medical director of the Hospital Home Program. This is our hospital home team at UMass Memorial Health. It takes a village, as I think all of us probably are very much in agreement with. And so just wanted to share our team as we talk a little bit about our program. A little bit about UMass and our home hospital experience with COVID in particular. So we are the primary safety net tertiary care system in central Massachusetts, really providing the majority of inpatient care for the most vulnerable patients, more than 70% of the care for patients with Medicaid in the region. We also operated the state field hospital for the state of Massachusetts twice during the first 2 surges of the pandemic in early and mid 2020, and then launched our home hospital program a little later in August 2021. With a focus really on high acuity inpatient level care. So we're not currently doing ambulatory monitoring right now out of the hospital home program or adjacent to it. Very similar to what Mike had shared, our providers are centralized and virtual only. Our in-home caregivers are our nurses and paramedics, and we've tended to insource the majority of the care team. We are an acute only model, so a 5 to 8 day length of stay versus a 30-day model. And a little bit about our experience with COVID. So, we're still a young program. We're about 7 months in. Of the now nearly 250 patients we've cared for, about 65 of them have had severe COVID as their primary admitting diagnosis. And then in terms of their demographics, they skew a little bit on the older side, mean age 63. About 31% have been non-English speaking, about almost 30% have been Hispanic or Latino, and about 6% Black or African American. And then our payer mix, very much aligned with our safety net role in the region, has skewed towards the Medicaid and dual eligible populations. Of the 65 admissions we've cared for with severe COVID pneumonia as their admitting diagnosis, 6 have escalated to the floor, 2 of them for respiratory condition or worsening respiratory failure, and the other 4 for non-respiratory related conditions. And so our escalation rate for COVID has been in the 9.5% range. So I could not agree more, Mike, with your point earlier around there being an intrinsic escalation rate. These are sick folks. And of our patients, 1 patient of the 65 with COVID who was admitted to us was escalated and then admitted to the ICU within 24 hours. And we'll certainly share a little bit more actually about that case a little later in that discussion. And just to share, I do think that it's very important to maintain a strong degree of humility. And, we're certainly standing on the shoulders of giants in terms of the work by Bruce Leff in the late 90s, the Hospital at Home Users Group leadership team, the CMS waiver team, our colleagues in Senate and Congress right now, and certainly the clinician scientists who helped us develop the vaccine, which lowered the population risk for home hospital, which developed disease-modifying therapies like studied disease-modifying therapies like Decadron, like remdesivir. We admitted our first patient in August of 2021, so later in the pandemic, and that did have some real advantages in that we had the learning and understanding of how to manage this disease that many home hospital programs didn't have earlier in the pandemic, just due to the early nature of the disease course.
Great. Thank you so much, both of you, for that background. And we're going to get into the questions we developed today. So the first question is, what are your detailed inclusion versus exclusion criteria for admitting COVID patients? And we're going to start with Taki on this one.
Yes, it's a fun question. I think really reflects sort of the flexibility of the care model to some degree. And we've actually moved a little bit away from condition-specific criteria in our home hospital to service-specific criteria. And what that means is we ask our care team to answer the question, can we provide the standard of care for this patient and maintain isolation precautions? And so below, I've actually shared our general inclusion and exclusion criteria for home hospital. And in the parentheses, I've put what we describe as essentially rough guidelines for our clinical team to think through. And so for instance, we're admitting patients who are adults who meet inpatient criteria and live in the service area, who have a low probability of requiring ICU level care. And so for us, what that means is certainly they're not actively intubated currently. They've been off BiPAP for 6 hours. The respiratory rate is less than 30. they're satting in a reasonable range on less than or equal to 4 liters of nasal cannula oxygen. And there's some additional criteria that I've listed there as well. However, there have been exceptions where we will routinely care for folks who don't fall within these neat guidelines for a variety of complex reasons around goals of care or other reasons. So I think we sort of do a lot of teaching and training around holistic risk balancing for our vulnerable population. And then I think, of course, we have to make sure from a home perspective that we have a home recovery environment with electricity and climate control, that they can meet the usual home safety criteria in terms of ADL and cognitive impairments, and we can support them through those. And I would say the one really nuanced piece for patients with severe COVID pneumonia is that we can then safety plan with patients and families around isolation precautions. And so there have been certain situations with high-risk family members where we cannot safely build an isolation plan for them in the home, where we will not admit them, but that has been actually quite rare, fortunately.
Our inclusion criteria at Mayo was quite like Taki's. I mean, almost the exact same numbers and trends. And again, there was a clinical screening. Was the patient clinically sick enough to be in the hospital, but stable enough to be watched in a home environment? Would they not need rapid escalation to ICU and such? Again, we took chances on patients, but we always kept the quality and safety #1 factors. And then, as mentioned before, really looking for that social stability as well. We have to make sure the home is the right environment for the patient to get better. Did they require a full-time caregiver? Did we have the social screening passed where we had the electricity, power, everything else in the home, or what things we could back up? And then finally, geography, they had to be within a certain mile radius for us to get our resources to them within the qualified time period, make sure we could have rapid responses, as well as the right payer. Up front, when we first started in 2020, there was no payers. Then the waiver came along, which really included all the Medicare, Medicaid patients, which was wonderful because that was a major part of our population that was suffering from the COVID pneumonia and requiring hospital care.
Thank you very much. And I'm going to keep on going with the questions, and we're going to with the questions we've developed here, and then we'll answer questions from the audience at the end. So question 2 is, how do you conduct risk stratification among your COVID patients? And this time we're going to start with Mike.
Right. We tried various scoring systems. We looked at the comorbid disease states listed here, the obese patients, the older patients. We tried to base what we looked at off of that. In the end, there's a lot of different criteria out there. There's a whole slide of them worth it here. Really, it was the clinically stable patients, even if they were ill, even if they had these comorbidities, if we thought they needed inpatient care but could recover in the home setting, we put them there. We did not, we knew people with comorbidities needed more watching. We made sure they got their 2 in-person visits. We made sure we had our resources available. We checked on them. We did not use continuous monitoring, which you'll see in a later slide, but we really took it head on. If they deserved, hospital level care, we took everybody despite these risk stratifications. The highest risk patients we did put in. Only the rapid clinical deterioration patients did we keep in the brick and mortar hospital. Everybody else we tried first with hospital at home if we could. These social screening factors really looked at the home environment itself and the protection of the staff and family members. Were family going to be around? Did they have COVID? Were they going to keep social distance? Would they wear PPE? And how would our staff interact with them? That was another form of risk stratification we had to do.
I couldn't agree more with everything that Mike just said. And I think a part of it is that early in the disease course, we had very little understanding of the disease itself, modifying risk factors. Nobody was vaccinated. And now we're in a very different world with a lot more understanding, more therapies, and of course, the vaccine, which really modifies risk. And so to Mike's point, I do think that in the current world, it's certainly possible to overthink some of the nuances. And so what we sort of emphasize is really the concept is one of, is this patient a floor appropriate patient? And I think clinicians have a very high degree of comfort with answering that question. And so we say to ourselves, if this patient is floor appropriate and we can provide the care they need, the default should be that we can care for them in home hospital.
Thank you both for those responses. The third question we have is some of the stuff you started to bring up. How do you maintain appropriate COVID precautions and work with the vendors in the context of COVID patients? So this time we'll start with Taki.
Yes, and I think there's some relevant context I'll just share. And one of them is we made some design decisions in terms of our program. We've mostly insourced our care. So our physicians, nurses, and paramedics were operating with the same EMR. We're joining morning huddle together and afternoon huddle together. And so it's, that core team knows this patient is on precautions as well. And actually our mobile imaging partner is currently the only outsourced partner going into the home that does not have access to and is operating within our EMR. And they actually go into every patient's home wearing full COVID appropriate PPE. And so frankly, we really just follow our system level COVID precautions. And so for our caregivers, we have a system level vaccine mandate for all, with a very, very few exceptions. And then we follow our system level COVID surveillance policy. So all admitted patients who are meeting inpatient criteria in the ED, they're all being swabbed before coming upstairs or coming into the home. Obviously, our clinicians going into the home are using their normal COVID appropriate PPE. They're donning and doffing outside of the home, and then we sort of double bag in biohazard bags and then dispose of that when they get back to the command center. And then of course we work to minimize in-home time wherever possible, using video and phone to do complex histories. And then for any outsourced caregivers going into the home, and this tends to be PT, OT, social work, speech language pathology, and then mobile imaging, there's communication at the time of the referral regarding COVID precautions. And again, actually our VNA partner that does those rehabilitation services is also operating within our EMR. So there's an extra safety check there as well. And then of course, for family members, we're screening for high risk conditions, making sure we can create an isolation plan. And then of course, we're bringing out, we're feeding the patient as well. And so there's a whole bunch of nuances around simply wrapping around services for the patient so that the patient's family can be isolated. And if there are ADL or cognitive impairments, we tend to be far more sort of prescriptive around the PPE in those situations. And there are certain situations where we can't safety plan, and then we will admit the patient to the brick and mortar.
Our vendors varied by site. So in Northwest Wisconsin, it may be 70% to Mayo Clinic and their vendor, and they're insourced, and then 30% outsourced. In Florida, it's the opposite. We had mostly outsourced. So it was really getting alignment of the groups and making sure that these people delivering the in-home care, one, knew that it was a COVID patient, two, knew the rules of what to do, knew how to get that indication to them, be it a sign or an electronic indicator, donning and doffing of PPE outside of the house. We did as well. What was the necessary in-home utility of what we did with precautions, as well as use of respiratory things like in-home spirometry and such, and what risk did that put both our staff or patients at. We also had to learn rules as we went. So as we started to have patients in ALFs and other things, they started to impose their own rules of COVID testing, of vaccine status. And we had these vendors who were not Mayo people who were delivering Mayo care. And we had to then talk to our vendors and say, guess what? You have to have a vaccine, or you have to be tested before you show up at this place to be negative. That was an interesting negotiation to have with somebody who is not under your thumb of control and making those connections. So we learned a lot along the way about what to do with this.
Thank you. Our fourth question is, how do you monitor acutely ill COVID patients, and what protocols do you use? So I think we're going to continue with Mike.
So as mentioned several times before, we treat our hospital home patients just the same as our inpatients as far as the degree of what we do. The one big difference is the continuous monitoring. I've always been an advocate that we do too much continuous monitoring in the hospital itself. So when we started this program, I tried to limit that. Limitations, the technology of continuous monitoring and a lot of the feedback and miscues and bad data you get kind of helped us out. We really just took vitals as we saw fit, either by protocol or PRN. We had no continuous pulse oximetry. Again, that was PRN. We found our patients did fine with that. We had standard COVID labs that we did in the house. We had APP visits as our in-home provider, usually with our most critical patients up front, days 1, 2, 3, and then backed off to more virtual if it was indicated. And then daily RN visits as set up by the waiver at least twice a day, with using paramedics and respiratory therapists as needed, both in physical and virtual sense. We found we were able to make several in-person visits, like with respiratory therapists, to set up care and then pass that on and do follow-up visits virtually so we could extend those resources, not send somebody house to house to house every single day.
I really like Mike's point around it's really the same care. And I couldn't agree more with that. And so what I'll just emphasize is what's the same about monitoring a patient with severe COVID versus other diagnoses in home hospital. And I think most of the approach and the philosophy is very similar. You still need to build a culture of holistic risk balancing in your clinical teams, balancing sensitivity and specificity of any monitoring approach, maintaining a therapeutic alliance, and then really training towards escalating a little too early versus a little too late. And I think we do a good job, certainly in general. And then in terms of the differences of monitoring patients with severe COVID in hospital home versus other diagnoses, on the history side, we do use an effort, or we do attempt to use more virtual visits on the provider side in particular to reduce lower value in-home caregiver time at the same time with our provider. And in particular, this can be very helpful for complex goals of care discussions. Frankly, I kind of argue you can actually hear the provider better if they're not wearing a mask too. So there's some advantages to the patient and family as well. And then there's certainly value in having a video translation service that is accessible via your technology platform, which certainly we use as well, so that you're not having an audio translation pulled externally from the platform. We do use a continuous pulse oximetry approach. I do think that, to Mike's point, for patients who are on 2, 3, 4 liters, that is probably a little aggressive, and you tend to get more false positives than true positives in terms of hypoxia alarms. There's some value, I think, in the sickest of the sick that we care for, but I think that's a judgment call, and many programs probably do very, very well, or definitely do very, very well, I should say, with an intermittent approach. And frankly, we're sort of migrating more towards a risk stratification approach, where for certain higher risk patients only, we're going to use the continuous approach. And for many normal risk, and when I say normal risk, these are still sick folks, inpatient level, high acuity sick folks, we will migrate towards an intermittent approach that aligns with what we typically do in the med-surg floor. But I think, to Mike's point, we certainly over-monitor many patients in the brick and mortar facilities, and we don't want to replicate that in home hospital either.
Great. I think this is getting to one of our last questions before we move to Q&A, which is, how do you manage advanced COVID-19 therapies like remdesivir or other treatments?
Definitely. And in a lot of ways, I'll do the same approach, which is sort of what's the same and what's different about managing a patient with severe COVID in hospital home versus this time in the brick and mortar. And so obviously, for folks who tend to be a little on the sicker side, so the folks who are on the 4 liters will bring a higher level concentrator. Everyone gets backup oxygen, and pretty much otherwise, it's all the standard inpatient med-surg management. Lovenox, dexamethasone, remdesivir for nearly all. We're continuing advanced therapies if they're coming out of the ICU and coming to us in hospital home. There have been some very rare exceptional uses where we'll give monoclonal antibodies in the home. And then in terms of what's different, I think the main thing is escalating a little bit on the earlier side. We prefer that patients have that we can escalate them to the med-surg floor directly versus having to send them through the ED. And so escalating 3 or 4% too early is probably always better than 3 or 4% too late. And I think that the one last piece I'd love to share, and this is a deeply personal story from a patient that we cared for very early. And so this was a 54-year-old lady that we cared for, unvaccinated against COVID, who presented to our partner ED with new severe COVID pneumonia about day 7 or day 8 of her course, was legally blind and was terrified about the hospital and terrified about the intensive care unit. And so she came to us and did very well for the first several days, and then slowly, unfortunately, escalated her oxygen requirement to the point where around day 4, day 5 with us, she was at a point where we would normally escalate her back to the brick and mortar. She categorically refused. She said, I would rather stay home and pass at home. And so every day for the next 4 or 5 days, we worked to understand her goals, address her goals, and really impress the seriousness. And ultimately on day 4 or day 5, we had her on 10 liters of oximizer. We were doing blood glasses in the home, very, very sick and not typically appropriate for home hospital. But we were doing our best to meet her where she was, got phenomenal care. Finally, on day 5, she ultimately accepted transfer back to our partner hospital and was admitted from the ED to the ICU and was ultimately intubated 24 hours later and tragically passed 5 days later. We received this note from her husband, and I think it was just both a deeply tragic, but also a reflection on the light that can come from these periods of darkness. And I think something that to this day still impacts our whole care team.
Yeah, I can't really beat that good story. And as far as us, it was using our own pharmacy resources to set up the infusions and distributing that to patients. Although most of our hospital home patients before we started treating COVID were used with vendor pharmacies, we knew that we had to deliver the right medication, and it was difficult. I mean, vendor pharmacies didn't have remdesivir to give on an outpatient basis. So building it within our own system was part of the protocol. And this goes to address one of the questions is, what do we do after this, after COVID? We built all these pneumonia protocols, the way we resource and treat this. We can pass this. So you have to have a plan of what to do afterwards. We're going to continue to treat multiple types of viral pneumonias using this same process, be it COVID or the next thing. We built all this. We can continue the good work moving forward. The other thing we did was partner with the COVID virtual clinic and outpatient clinics to complete treatments. Just like you have somebody in the hospital who's ready to go home on day 3, but they need 2 more doses of remdesivir, but they're looking great. We did not keep them in our hospital home program. We kind of did an outpatient hybrid of outpatient treatments in order to get them, quote, discharged out of the hospital home program. We treat these people the same as inpatients. We really try to, optimize their care, reduce costs, reduce resources, and do what's right for the patient.
Thank you both. So we have a number of questions. So the first question is this program independent of hospital protocols and mandates? Does it offer more flexibility for patients to negotiate treatment options? Maybe I'll start with that, and then I'll get to the third one of this person's questions.
Go ahead,
Anyone
Doc. You can start. We'll just go back and forth. You can start.
Sure. Now, this is a very interesting question. And so we took the approach that the default in general would be to fall back on our hospital-based policies for most of the diagnostics and therapeutics, and then adjust the real critical ones. And so the ones that we ended up diving a little bit deeper and making a number of adjustments were around our pharmacy management in the home in particular. So a lot of nuance there. We could probably talk for hours about that question alone. Mike, to you.
We did the same. We did the exact same. It was, CMS, when they broke out the waiver and actually had some sort of payment structure and organizational structure, they did not require much. What's your volume? What's your escalations? Who died? That's really all they asked for. We still stuck with all our quality metrics at hospital and home that we're following, and we kind of keep that top quality care. We wanted to be safe. We wanted to be the best quality. So just as Taki said, we followed our same kind of standard protocols and quality metrics.
The next question is, I think, a more general question, but still very relevant today, is if the current waiver to the hospital conditions of participation is not extended, what, if any, options are there to continue this program? Implications for reimbursement, hospital compliance considerations?
Sure. I think, that makes it a lot tougher, of course, but I think there are a few options. First of all, commercial payers, you can partner with a commercial payer, create a bundle or whatever you want, and that's outside of CMS or other payments. So if the conditions of participation are not extended, you can build bundles with individual payers to pay for this. There is an outpatient model that you can follow. It is one that, you could base it off of CMS bundles, where you keep somebody in the physical hospital for 2 days and then continue the rest of their 5-day or 6-day hospital course at home. Or, you can take some of this hit on yourselves or try to find other ways of paying for it, just to prove the data, prove that this works while we continue to lobby. So there are options. It makes it tougher for sure, but we had built our program before the waiver even came out. It was an outpatient-based program. We called it hospital at home, advanced care at home, but we built it off of outpatient processes. So there are ways to get it done, and there's accountants and support policies and lawyers all that worked all that stuff out, that we could take care of these patients in that way. We just wanted to prove that the program worked.
Agree with everything Mike said. And I think, flashing back to the first slide or one of the very early slides, call your senators, call your congressmen, call your government relations teams. This is a really big deal for patients, in particular the most vulnerable, who we know do well, disproportionately better in hospital home versus brick and mortar. And so I think this is just a real moment to come together around the data.
Part of the last part of that person's question also involved hospital compliance considerations. So if the waiver goes away and you're operating under a commercial bundle or managed Medicare, what do you think about the hospital compliance considerations?
So to some degree, and I'm certainly not the chief compliance officer of our health system by any stretch, so hopefully I'm not horrifying our chief compliance officer as I say this, but the commercial contracts, obviously there's certainly contractual obligations within existing commercial contract structures. Some of our local contracts actually allow for home hospital within their existing contract structure, because it's simply acute care. It's acute care, it just happens to have part of it in the home. Obviously, the scrutiny around Medicare and Medicaid and the government payers is much, much higher. And so obviously there's a lot more of a nuanced discussion there. So Mike, to you.
Yeah. Agreed. We would have to follow any metrics or quality metrics built into those particular contracts. Besides that, from the government standpoint, there are no real rules right now. We're trying to build them as we go. That's part of this hospital home users group and other coalitions that have gotten together, trying to write those type of metrics and define those things, because we know they're coming. But how does ACA play in this? How does JACO play in this? What is accreditation for a hospital home? That has not been answered yet, and we're kind of building that as we go.
Thank you. The next question is about PPE usage. Now, we may have gotten to some of this in the presentation, but I'll read it nevertheless. Just curious about the PPE usage, supplies, and maintaining sterilization precautions across different health clinicians involved in the acute home care. Any difference from the usual home visits, considering the quote acuity?
In our program, we followed the same protocols. It was really informational communication. People had to know they were going into a home, they needed to use PPE. We had practiced and simulated that with other patients even before COVID when it came to other type of contact precautions for C. diff and such. But really it was the communication. And then if these vendors, especially that were not Mayo, did not know what to do or did not follow those precautions to a T, we would do simulations for them and just practice with them and show them how to do it, what our protocols were, so they could pass that on to their staff.
Agreed. Echo that point, certainly.
Great. And then there's a question about why did you start these programs? Did you go into this mainly to address capacity issues, or was there a value-based care approach as well, i.e. lowering total cost of care? And if there was a value approach, is it working?
Yeah, yes, it's such a fun question. And I think probably my guess is at least certainly I'll speak for myself, am quite biased in this answer. And that the nice thing about answering this question is that there's a lot of ands here as opposed to ors. Our C-suite level team at UMass Memorial Health feels very strongly this is the future of acute care. So there's a very broad strategic vision. There's also some very tactical day-to-day. Our very busy medical center that is the trauma center that is providing the high acuity, the transplant care for the region is just really, really underbedded, and we need some additional capacity. And it's a care model that we know is safer, it's effective, it reduces readmissions or mortality. So there's a lot of ands that come along here from our health system perspective.
Yeah, I mean, I think a lot of people got into it for capacity issues. We were planning on this before. We thought that this was part of the medical package and how advancing care was going to move forward. I mean, buildings cost a lot. 150-bed hospital cost you $500 million to build. A hospital home program might cost you a couple million for the same 150 virtual beds to build. So there is a cost savings there. Hospital costs 50% of what patients get billed are not even true care costs. They're just paying for that building, the lights, the power, the sterilization, everything going around, cleaning the sheets. So we remove those costs, but we have to pass those savings on to the patient. Then there's this value equation of not only just the black and white costs we save home versus the hospital and those raw costs, but escalating the home, preventing readmissions, opening up the beds for other cancer surgical patients so they don't have to wait and get sicker, giving people not only acute care, but restorative care and continuing RPM type of monitoring, passing them on better handoffs to their primary care providers or consultants, educating them about their disease state so they live a better, healthier life. There's a value there. All those things add up to some equation of some sort of savings that we can pass on to the patients, to insurance, to the system. We just don't know what that number actually is yet. We're working on it together.
I think I'm going to just skip to one question that I saw in the chat that I thought, although we prefer the questions in the Q&A section, I'm going to take one from there, which is, what keeps you up at night?
You can start talking and then I'll, besides my children, yeah, go on.
Right. I would say that the near term has been the CMS waiver above and beyond all. That's the one that is, I think, just critically important for our patients and system. Yeah,
I think for me, there's the answer you expect, which is, with this hospital home program, do I worry about my patients not being in the hospital? Of course I do. They're away, but we built the system and we've tested that response so well that, I trust the system. I trust what we build. I trust what Taki's done and what Dr. DeCherry's done. It all makes sense. So what keeps me up now is the future of these programs. Of course, the uncertainty about the post-pandemic state and where we're going with payment. And then the other thing, I think the main thing is the workforce of the future. Okay, if we're decentralizing healthcare and building in these communities, there's only so much workforce out there. I mean, the whole reason hospitals exist is to put everything in one building. Now we're decentralizing healthcare. We can extend it to many different areas and help many different people, but we need a new type of workforce, not only the people that are there, but new jobs for our nurses, our paramedics, our physical therapists in the community, building that workforce through education, partnering with universities. That's a huge onslaught that we'll have to do to build the workforce of the future, to power these jobs. And remember, we're starting this with a lot of outpatient nurses and outpatient people now that are practicing inpatient acuity care in the home. So education of even our current resources is important as well. And I think that's what I foresee as one of our challenges in the future as this type of model catches on.
Well, this one lead right into one of the other questions, is because both of your programs involve paramedics. And so the question is, do you provide the question is EMTs, but I think it can be any paramedic EMT additional training. So if you want to describe a little bit about that.
Yes, it's a really fun question. It's an important question. You know, just to set a little context, our 911 local EMS and actually much of our regional system is backstopped by the medical control from our own UMass Memorial Health providers. The MIH team is actually an employed MIH team within the UMass Memorial Health system. So these are typically folks who have been practicing as paramedics for 20 years. They're excited to do more, to keep folks in the home, and they do undergo additional training both before and after they come and work directly with our hospital home program. And they are an absolutely lovely group of clinicians to work with. And we have a hybrid model where we have both nurses and paramedics working side by side. I think to Mike's point earlier around the workforce of the future, I do believe quite strongly there is no perfect caregiver currently for home hospital. Everybody brings different strengths and we all have to train and learn from each other. It's a little bit of a flashback to the old school generalist model. And we've moved away from that in this country, and we're now moving back a little bit towards it, which is partially why I think many of our geriatrician colleagues are saying, "Hey, we were always here. You're coming back to us finally," which I love. And so I think that there is definitely a world in which we have a lot of humility around learning from each other.
Yeah, I'll just tack on. It's a team effort, and we do educational programs for paramedics to teach them how to, change a sterile dressing on the central line. If they've not done that before, let's bring you here to our simulation center, show you how to do it, educate everybody. We don't want anybody to practice outside their scope. We practice within scope, but we know the future has jobs that don't even exist nowadays that we will extend to paramedic staff and nursing staff. I'm thinking of Paramedic Plus, which is, we took nurses and over the years built nurse practitioners. There's programs like that for these in-home services of infusion nurses, paramedics, home physical therapists, where there's this plus model that treats high acuity care in different ways. That'll take education, that'll take partnering with institutions to build it, but there is a model for that moving forward.
Thank you. And I think that's so important to talk about this training. In a similar way, there's a question here, not about training of people, but about the logistics. So the question is there a suggestion for care coordination from the logistics standpoint? It is a complex workflow to solve, which is very true.
Yes.
So how have you both solved that?
I mean, from our standpoint, that's why we have a partner to help us with the workflows and the vendor resources. I mean, you think one patient getting one dose of remdesivir, you need a pharmacy to mix it up someplace, somebody to deliver it, somebody to deliver tubing, a pump, a nurse to go there and infuse it, somebody to take the medical waste away, somebody to document it. That's just one person, one dose of one thing. And you're doing this over hundreds of patients over long distances. There's so much logistics to it. There's, several companies that are building to that. You partner with them. You build the workflows through institutions, you make it safe. It's a tough thing, but as we get better, as we do it more, as we all get together, share lessons learned, share the same resources, share the same supply chain, build upon this, you can build the system. I mean, shopping was once all in department stores. Now shopping, when I say it is department stores, but it's also a lot of online stuff. It was built over time. It took 20 years to get to that point, but we did get to that point. And I think the logistics of this is just the same, if not more so, because we're looking at quality, safety. This is somebody's life. You have to protect that. So you have to build it right.
Here, I could not agree more. If you enjoy and love logistics, home hospital is the place to come and put your talents. You're hired tomorrow. Yes.
Thank you. Similar to the question, there's two questions a little bit about staffing. So there's one question about, are you using nurse navigators to screen inpatient ED for the appropriate patient? So I guess getting at really how you're identifying the patients and who those people are. And then there was another one about the staffing, which I think you both touched on a little bit early on, but maybe to remind everybody about who's insourced or maybe outsourced in your models.
On the patient acquisition side, I think this is one area in which it can be very easy to underestimate how much work and change management is required upfront. And so the way we viewed it at UMass is that this is an investment that is going to take not days or weeks, but really months and years to bear fruit. And so what that means very tactically on a day-to-day basis is we have nurse care navigators essentially screening every patient in both of our tertiary care facility ED and floors every single day, and then reaching out to the teams with a little bit of a provider nudge and additional support around, hey, this is what we can do in the home. And there's a whole strategy and discussion around the change management. I think what you will sometimes find is that if you underinvest in that in the first days to weeks of a program, you can think that if I build it, they will come. But if you build it, you need to then do the change management, and then they will come. And so we're 7 months in, and I would say that we're over the first hump of the change management, but certainly not over it entirely. And I think we're going to be continuing this process at least for the next 3, 5, 6, 10 months.
Yeah, we learned the same thing. Our acquisition was all manual up front. We have built some AI type systems into Epic where we can grab geography, payer, diagnosis, limit the list down. Instead of 300 patients, here's 20 that you can look at, but it's still a pulling type system of us with acquisition teams pulling. Eventually, what we hope is a push force system where people know, okay, you meet inpatient criteria, you need to be admitted from the ED, the clinic, wherever you're at. The first line of defense, hey, is this appropriate for the home setting? And being pushed to us patients by all the medical teams and consultants and ED. That's really what we hope for, because that's what we do for everything else. ICU doesn't go out looking for patients. You push somebody to ICU when they get that sick. It's push everywhere else. For this right now, it's pull because people aren't used to it. They're just getting used to it. Eventually, we're going to fall into that push type of system.
Agreed.
Yeah. As far as staffing goes, again, with Mayo, it depends on site. Insourced 70% in our Wisconsin site. Outsourced 70% in our Jacksonville site. What we insource here in Jacksonville really is the clinical care. Besides the virtual aspect that we always control, it's the APP. In Arizona, it's 90% outsourced. Everything's outsourced except for the APP doing the in-care visit and giving me my physical exam data at home. And really, we wanted to control the clinical aspect of this. We wanted that to be Mayo level care. If I decide somebody has heart failure and the solution is IV Lasix, it doesn't have to be a Mayo nurse at the bedside pushing that Lasix. I can write that order. I can watch it happen. I have quality standards for all my vendors. We don't let them slide by. We do, every 3 months type of review type of things, but we have to learn to trust your partners in the community if you need those resources. If you're blessed with a lot of resources, great, but sometimes you have to partner. We found we did, and it's worked out well thus far.
Yep, I agree with many of Mike's thoughtful points. We tended to insource more of our acute and virtual care team. So right now, our care team is providers in a command center, clinical coordinators in a command center, and then bedside staff nurses who tend to be a little bit more acute trained, although we certainly have a mix of talents and skill sets. And then our outsourced partner is really entirely around our VNA partner for PT/OT, social work, speech pathology, DME, and then mobile imaging. Those are the 3 sort of core outsourced functions for us.
There's 2 questions here that I'm going to put together, which is one about what are good quality measures to help track progress for a successful hospital at home program? Are there any custom ones? And the other one is about patient experience. And then I'd like to put a little bit of back to our topic today was, did you find any differences, or even are you tracking differences for COVID patients? I think both of you alluded to escalations that you might have expected a slightly higher escalation rate, which I assume is one of the metrics you're measuring. But are there other things that are COVID specific that might be different in other metrics or patient experience?
Go ahead, Taki.
Mike, to you first.
Okay, fine. As far as
I made it too
metrics-
complex.
No, it's fine. As far as quality metrics in general, that's a great question. What do we follow, and do we count it the same? Falls in a hospital are counted by patient days, and do we count falls at the home the same? When you look at the data, people are up out of bed at the hospital 1 to 2 hours a day. In home hospital, they're up 8 to 10 hours a day. So if you both have one fall, but you're up 10 times as much in a different program, is that really the same metric? So we have to figure out what is the most important thing at the home. What are the new things we never talked about, and it's number of cats in the house that people trip over. I mean, there's so many things out there that we have to figure out what is a true quality metric. There's no rules on this. It's kind of the Wild West. We're using inpatient stuff, which counts for some, but not all, and twisting it to what is the right thing for the patient, to keep the patient safe, to get the right quality metrics. That's why this, Hospital Home Users Group and other coalitions exist, to figure that out. It's difficult. When it comes to experience, we're judging experience on the patient itself. We ask about the virtual interaction, the physical interaction, the technology. It's more expanded than your HCAHPS. Some of the HCAHP questions don't really, did you get help getting up, going to the bathroom? Well, how do you interpret that when somebody's at home? Is it with our caregiver? Is it with the family member? And it's hard to interpret a straight up HCAHP question there. You have to tweak it to the situation. You also have to gain the experience of the caregivers at home, the family that's there. We don't want the family to be nurses or PCTs. They're supposed to be family, but they do help out. They do get educated. How do you judge that interaction, collect data on that? And then provider experience is just as important. We collect data on that to see, how do you like using the program? Do you feel safe using it with your patients? These are all important things. We are collecting the data as we go, both for COVID patients and hospital home patients, and publish as we get enough data to move forward.
I agree. And obviously the CMS waiver metrics and then your hospital or health system based metrics tend to serve as the foundation, to Mike's point. And then there are, and certainly the HCAHPS scores tend to serve as a foundation, but there's so many things that are just not relevant. I was just looking at our own patient satisfaction data yesterday, and in terms of top box, hospital recommend, like all of our metrics are really, really impressive. And then it turns out that half of our patients think our home hospital is too loud. And so it's just hard to know what to do with that, really. How could we have made that better? So there's things that are just less relevant, to Mike's point. And I think your point around falls in particular, the best way not to fall is to lay in bed and lose and develop sarcopenia and then end up in a skilled nursing facility. And that's obviously bad for the patients, bad for the family, it's bad for lots of folks. And so, we need to activity just falls, to Mike's point. So there's still a lot more nuance and learning to happen over the coming years.
Thank you. Now, there's a couple questions here that I will throw out there, and we'll see. Some of them we may not all have the answers to, but we'll try. So the first one is, some hospital home programs are supported through CMS, and there are legislative policies, state or federal, that could help support hospital at home initiatives for the commercial insurance perspective?
That is a very, very interesting question. And Mike, I'll certainly share the Massachusetts experience, and you have a very unique experience operating in a regional base or multi-regional basis. In Massachusetts, the state Medicaid has been very, very supportive of home hospital, including language being built into existing Medicaid acute contracts, even prior to the waiver. So I think, we're very blessed to have a very progressive Medicaid system that we're very closely partnered with. The Division of Insurance actually passed a mandate during the Omicron surge in the last 2 months that mandated coverage of all payers in the state for 90 days of home hospital. So that's helped a little bit in terms of setting the conditions and foundation for further discussion with our commercial payers. For the most part, the commercial payers locally in Massachusetts are very, very supportive. And so we're just now having that conversation. And I think to some degree, the advantage is that, this is just acute care. It just happens to be partially in the home. And so it's really, we're trying to sort of simplify the conversation a little bit and essentially just say to our payer partners, this is the same care we've contracted for, it's just better and you're getting more value. And so I think that can often be a compelling discussion. Would love to hear your view, Mike.
Yeah, no, it's difficult. And seeing it, each state has their own laws, regulations for pharmacy, paramedics, all these other things. So it's reinventing the wheel each time. Everybody's a little different. I have to remember, well, who can I use in this state? And it is tough. If we had some global ways of, the problem is that care for hospital patients is linked to a building in legislation right now. And we have to unhinge high acuity care from a building. Once we do that, even on a federal type of mandate, then it'll be much easier with the states to build these rules and regulations and not have to reinvent the wheel each time. That's what we have to do to decentralize the care that we're giving.
Thank you very much. I think with that, we are going to stop. We peppered you with a lot of questions for 25 minutes here, but I know Gabby has some last minute things. There are a few questions here that involve like about the application process. Please go to, for the waiver, the application process for the waiver, please go to the Hospital at Home users group website and under Technical Assistance Center, there is information on that particular question. But now I'm going to turn it back to Gabby, who had a few more things to tell us about.
Thank you so much, Linda. And thank you, Dr. Maniashi and Michaelides. So just to close out, if you want to join the Hospital at Home Users Group, you can head over to our website at howusersgroup.org. We also have a lot of technical assistance available on our Technical Assistance Center, such as the annotated CMS waiver. And again, we just want to thank the John A. Hartford Foundation, the American Hospital Association, and the American Academy of Home Care Medicine for their support. Thank you all for joining us today.